Hello, everyone. Thank you for tuning in to my peer support training. I'll be covering peer support programs in the U.S. military, ethical challenges, and strategies to address them. My name is Amy Blackman, and I'm a graduate student at Colorado State University Global in the master's program for military and emergency responder psychology. So thank you very much for tuning in. I do have a few disclosures before we go any further, and that's, as I'm sure you've seen on the PowerPoint that I sent you guys via email, there's a lot of let's just say some of the slides are full of information. And a lot of times I'm just going to give them kind of a glancing blow and then move on. But you have all this information. And of course, I'm available to answer any questions throughout this training and after. So let's get going with the training. All right, training goals. Pretty simple. Just interact and learn from me and from each other. I love questions, thinking out of the box, sharing ideas, all that stuff. You do need to gain a working knowledge of peer support programs. Of course, specifically in the military, that's what this training is all about. And the challenges that go with the peer support programs and strategies to address some of the challenges, not all, or this PowerPoint would be ridiculously longer than it already is. Anyway, need you to, obtain some of the required competencies to get your certification as a peer support specialist, and let's have some fun. All right. So in 2012 is when an executive order was signed by President Obama for the VHA, or the Veterans Health Administration, to hire 800 peer support specialists for mental health and substance abuse care, supplemental care. In 2013, the U.S. Department of Veterans Affairs Veterans Health Administration, that's a mouthful, published its Peer Support Toolkit, implementing peer support services in VHA. Now, I use this a lot. It's the only toolkit that the VHA offers, and so I reference it quite a bit throughout. The cool thing is now, currently, according to the VA, there's over 1,200 paid peer support specialists working in different VA support specialist programs, such as inpatient mental health, outpatient mental health, intensive case management programs, substance use disorder programs, mental health rehabilitation, vocational, homeless programs, a lot of activity there. And then just in primary care, patient centers, specialty clinics, and that kind of thing. So there's definitely opportunity. So who are you guys? Who are peer support specialists, or who should peer support specialists be? Now, the good thing is you've all been vetted and, are training to be peer support specialists. So, there's been a lot of good words put in for you, and, the people that gave you references made sure that I knew how passionate you were about learning about this and then implementing it as in your career. But anyway, so peer support specialists, of course, they're peers, and they need to have as much affiliation on as many qualities as possible as the clients in the peer support program. I got a little cold. Essentially, they have to have a lived experience with the same illness or as close to the same illness as possible. Successful recovery engagement is something that we're going to talk about later. So keep this one in mind. It's must have successful recovery engagement. And then, of course, certification as a peer support specialist, which, again, this presentation is not all inclusive, but it will definitely give you um, a good set of required competencies to move on to the next step of your certification. The cool thing about veterans that become peer support specialists, which you all are, is that you understand the clients in a way that civilians can't. Study after study after study has shown that, and I mean for decades, the veterans would much rather talk to somebody that's been there, done that. Some of them, and we'll talk about this a little bit later, some of them don't trust civilians, like at all, like, um, which could be a problem and certainly an ethical challenge that we're going to dip into a little bit. But when veteran peer support specialists work with the clients, they enhance uh, the feeling of brotherhood and sisterhood and shared identity and belonging, which to me, that those are all good things. I think we all know that when service members come back and transition into civilian life, it's not easy. It's many have said that it's the hardest part of being in the military is either retiring as a veteran or going back into civilian life after a deployment, particularly one that involves combat. So what we're seeing is a lot of veterans coming back, service members coming back also with complex comorbid mental health and well-being difficulties, which include quite a lot. PTSD, traumatic brain injury, or TBIs is referred, depression, anxiety, anger, drug and alcohol addiction, as I said before, homelessness, relationship breakdown, criminal offending, which we're seeing much more since most of the folks from Afghanistan and Iraq have come back. So that's a bit of a concern for me personally, I guess, as I'm also into criminal justice. So we'll see how that turns out. But also the problem of vets coming back and really isolating themselves, being excluded from social activities and so on. This is stuff that we need to help with. So it's super important for us to be ethical, empathetic, and positive role models. They need us for that. PSSs engage clients in mental health and or substance abuse treatment by destigmatizing their decision to seek treatment. This is big. Encouraging the engagement in and adherence to treatment. Now, we know that it's one thing to get somebody in the door to a facility or clinic or whatever. It's another to get them through the entirety of their treatment plan. So that's obviously super important to adhere to treatment. They respond to the strengths and desires, what it is that their clients need. Utilize recovery-oriented patient-centered care. That's big. And you help your clients experience the less negative self-stigma, which goes in all of this, improved health and wellness, and just an overall better quality of life, which, again, I'm all for that. As PSSs, we are better able to empathize, assess social services. We have just a better knowledge base of that, connections, maybe networking, so on and so forth. And then responding to the strengths and needs of our clients. We're better able to do that. And though some of us struggle with, being tolerant, flexible, patient, and persistent, sometimes especially patient, it's definitely something that we need to, really work for. So just a little bit more information about who peer support specialists are. They enhance social networks, facilitate peer support activities, kind of get the group together, shall we say. Again, very recovery, patient center oriented, emphasizing treatment, engagement, and treatment. And this is made more relevant through the collaboration and the kind of the oneness of the situation, the normalization of the situation. Like, you get me. That's why it's so important, um, especially for those life experiences. Case management is important aspect. Um, it's not a full blown duty of being a PSS, but it's super important to provide that system navigation, um, help them to increase access. Like I said, maybe there's a network of people that um, easier access. I know I've worked in criminal justice in Colorado for almost 25 years, and I have a ton of different network connections depending on what it is that I need, and that's um, comes in super handy to say the least. So activating clients by helping, being role models, teaching the coping skills, focusing on the meaningful life roles that they, are coming into after coming out of the military, right? I mean, this is kind of a different chapter in their life, shall we say. So also really helping with the community reintegration. I can't tell you enough how the social isolation really impedes um, anyone having mental health or substance abuse issues. Excuse me, a cold. It's just very, very difficult to do it alone. Um, Additional benefits for clients that work with peer support specialists: there's less inpatient time, better treatment engagement, better social functioning, um, more time and engagement with the community, fewer problems that come up. And of course, when they do pop up, there's somebody there to help, which creates, again, like I said, just a greater satisfaction in life. Just real quick, I want to go through this table of do's and don'ts for peer support specialists. We do facilitate peer groups. We do not provide psychotherapy. That's not what we're trained for. That's not what we're equipped to do. There's other people in the multidisciplinary team that'll take care of that. So we need to stay in our lane, essentially. Share recovery stories. That's a definite do, as opposed to, again, stepping out of your lane and doing other people's jobs. We're client advocates. We talked about that a little bit, but we certainly don't, I should say, collude with clients against clinical staff. That's just super unprofessional and, just a big don't do. We need to act as models of recovery. We ourselves are in recovery, and we need to act as models of recovery to, again, normalize and encourage. As opposed to crossing boundaries, which we're going to talk about in much greater length here coming up. Providing crisis support is important to have that kind of training. I'm going to steer you to some seminars and workshops and stuff through the VHA that can help with all of these kinds of things. I mean, if you're not trained so much in like crisis support and intervention, it's definitely something you need to look into. We also do not support clients in any of their self-destructive or illegal behaviors. Again, just a big no-no, and I think the beginning of a slippery slope, I would say. Communicating with clinical staff as opposed to criticizing clinical staff in front of clients, again, super unprofessional and a big don't do of peer support specialists. Again, advocacy, working as a liaison between staff of the agency or organization and then clients, or being a liaison between other treatment agencies that may need to take over a portion of treatment, something specialty. I can't think of anything right now, but you know where I'm going with that. And then one of the biggest suggestions that I have from my 25 plus years of working in criminal justice, doing case management, paraprofessional, and therapy and stuff like that, is I think a lot of my best education through my profession has come through working with a variety of multidisciplinary teams and clinical teams. I cannot tell you enough if there's an opportunity to sit on a treatment team, a clinical team, multidisciplinary team, whatever they call it, I highly suggest you jump in. They want to know your impression of the clients, and um, hopefully you'll want to know a little bit deeper information about the clients that you're helping as well. So what do you guys think about these? I mean, can you think of any other do's or certainly any other don'ts um, that peer support specialists, it says expectations, and I think it's more than an expectation. It's just it's I like their expectations because it kind of sets the stage for this is what we do, and then this is what, wait, I'm pointing, this is what we don't do, right? There's also a thing that kind of goes along with that, which is called peer drift. Now, we have a peer identity, which you're developing now, which I have, but there's also instances where peer supporters kind of drift away from what they're there for. A couple examples of that I'll go through. So you have some comfort using your recovery, not some comfort, like you've got it pretty, buttoned down. You have it, you feel very secure in it. Your supervisors have approved it. It's genuine. As opposed to when you drift, there's a discomfort using your recovery story as a tool, which can be a huge challenge, a huge barrier to providing peer services. Um, Peer identity indicates, or an indication of peer identity, shall I say, is you see that relationship as a mutual learning experience between yourself and the client, as opposed to kind of what we talked about before, seeing that relationship as a way for you to provide expert instruction to people that don't really know any better at the beginning of their journey. We definitely want to focus on client strengths, skills, and opportunities as opposed to the problems, barriers, symptoms, and their diagnoses, because as part of that multidisciplinary team, staying in our lane, again, what I'm saying is extremely important. So we don't need to focus on that. We can focus on strengths um, and encouragement and motivation and let the therapist take care of the the diagnoses and helping them with their symptoms. That's what they're there for. Um, Strive to keep interactions real. I guess that's the best way to put it. Simple, authentic, real, as opposed to taking like a distance, very, very distant interactional approach style. It's more professional, more objective, focuses on standards and stuff like that, as opposed to focusing on being subjective, working with the client, being flexible, and having that human connection. Um, Again, we're advocates for clients. They're in their recovery, so we need to, help them find their own voice, make those choices, self-determined. Um, it's in the service of their recovery, so we're a huge support in that, as opposed to like discouraging folks to not listen to their therapist or not take a certain medication or just kind of advising against standards. Uh, Again, very unprofessional. So another challenge is when the peer the the peer supporter will actually avoid certain subjects because they're symptom inducing. We're going to talk about that a little bit later, but that's something that we all need to take into account is noticing when we're kind of avoiding subjects that are sensitive or still triggering for us. Again, that may mean that we just need to take a step back and consult with not our therapist per se, but the supervisor of our peer support program, a trainer, whatever. Consult with folks that have I've been doing it much longer. Again, peer identity is indicated by having self-confidence and security in your role. You're prideful. You like what you're doing as a peer support specialist, as opposed to like drifting into self-doubt, insecurity, shame, even. Again, that really is going to be a time for us to kind of check ourselves before we wreck ourselves, shall we say? um, yeah, it's time to step back. All right. So just really briefly, I want to, before I move on to ethical challenges, I want to just introduce you to some of the different resources I utilized quite a bit in this training. Um, I talked about before that peer support specialist toolkit, invaluable. Also, as a clinician, I I have to adhere to codes of the APA or the American Psychological Association, so their ethical principles of psychologists and code of conduct. I go by that, and the American Counseling Association or the ACA's code of ethics and standards of practice. I also use through an ethical decision making model that we're going to go through much later in the presentation. I use the ACA's Practitioner's Guide to Ethical Decision Making. So again, guide after guide after guide as to, you know, how to make the most of a peer support program. Again, I'm not going to go through this extensively, but the part of the APA, the code of conduct, but they also have the general principles that they go by. And again, you have this in your packet, so I won't exhaust it, but principle A is beneficence, my bad, and non-maleficence. I can't even say that. Non-maleficence. There we go. Whew, I'm not even gonna try that again. So we're endeavoring at all times to benefit our clients and avoid harm. That's monumental. It's huge. It's primary. It's principle A. Principle B is fidelity and responsibility. Now, fidelity is obviously a word we hear in the United States Armed Forces all the time. But as the mental health professionals, we have a responsibility to the clients in our PSP, institutions, communities where we work, all of that, to create a relationship of trust. Um, yeah, trust that upholds professional and ethical standards. So integrity, that's obviously a very huge part of um, some of the value sets of the United States Armed Forces. Uh, Obviously, accuracy, honesty, truthfulness, um, making efforts not to engage in unethical behaviors. And also, what I say about integrity is do what you say and say what you do, right? If you say you're going to do something, if you're going to tell a client that you're going to look up a resource or make a referral or something like that, and you don't do it, that that takes your integrity takes a hit at that point. So justice, we're all pretty aware of, you know, acting to avoid unjust practices, potential bias, being aware of potential bias, our level of competence, which we'll talk about later, limits of expertise, which is an ethical challenge that we'll talk about later. Um, and then just respect for people's rights and dignity. I mean, I can't express that enough. You know, we have to respect each other's dignity and worth. Um, you know, think of folks as being valuable. We have to be aware and respectful of vulnerabilities experienced by different groups of people. I love working with diverse folks. You know, it's more challenging, it's more interesting, and often more entertaining, quite frankly, to work with a big group of diverse folks. It's a lot of fun. So we have to be aware of groups diversity, cultural competency, and stuff like that. And that is considered to be critical, actually being culturally, can't even talk, culturally competent. That's a pretty big deal. So we're going to talk about 6 challenges, and this it is by far exhaustive of all the ethical challenges, but I think it will give you a good uh, foundation to go on in your training for your certification. So we're going to talk about privacy and confidentiality, informed consent, boundaries in dual relationships, continuity of service, competency and expertise, and countertransference. Can anybody think of any other ethical challenges? Does anything come to mind? All right, so let's start off with privacy and confidentiality. Um, as a peer support specialist, you may likely have access to your client's medical record, and you definitely have access to what they talk to you about as their peer supporter, right? You have that information. Thing is, the clients desperately want, especially military service members and veterans, desperately want that information to remain confidential, private. It's sensitive. They don't want it out. I can't blame them for that, can you? Um, but they worry that that confidentiality is somehow going to be breached. And the problem with that is that it creates a barrier to them, admitting that they have a problem with mental health or substances, again, usually co-occurring, um, and then seeking treatment. So they don't even want to acknowledge that they have a problem because they're too worried about the confidentiality being breached. Obviously, a huge challenge. Um, and a lot of times they don't even step in the door because they want nothing in their military record to reflect anything about, honestly, I would say challenges of any kind, whether it be relationship challenges, substance challenges, um, just sexual orientation, even that. Um, even though it's not as big a deal, I think these days it's still sensitive and private information that not everybody wants to be disclosed. In particular, active duty service members fear that leaks of confidentiality of their information will result in, and we've seen this over and over, it happens, being categorized as unfit for duty, which means you're taken away from your duty, and you're possibly also facing, or a fear is that you're possibly also facing total discharge from the military. Um, the thing is about that, that's a gift that keeps on giving because a dishonorable discharge makes getting civilian employment even that much harder. So one strategy to address this issue is that, of course, supervisors, trainers like me, we need to ensure that everybody's on the same page when it comes to understanding clients' rights to privacy, confidentiality, and prevailing standards of confidentiality, and of course, exceptions to the rights. Um, there are some things that we absolutely have to disclose if one of our PSP clients tells us, and when that disclosure of confidential information may prevent imminent, serious, and foreseeable harm to the client or to a third party. You can add to that designated location, like I'm going to blow up a bank, or um, I mean, my mind just goes wild when I start thinking of that kind of stuff. So I'll keep that to a minimum. But anyway, imminent, serious, foreseeable harm to either themselves or to someone else. That is something that that is an exception to confidentiality or a limitation to confidentiality. I say this quite a lot. We have to be able to articulate different not just articulate, be able to discuss not just the challenges that we face with the privacy and confidentiality, but how are we going to overcome those challenges, right? That's super, super important. So basically just it's a rehearsal. Um, it's just part of getting ready, getting your certification as a peer support specialist, and then working in that in any capacity. One thing I did do was forget to take the highlight off of some of these slides, but that's neither here nor there. So I have to, like I discussed earlier, I have to apply the APA standards and guidelines, and I have to apply the ACA. And as a trainer and in development of your peer support program, I would, like I said before, I highly, highly encourage you to take those steps to um, get yourself versed in these. And of course, they're in the PowerPoint, so I've done all the work for you. So just briefly, and again, a lot of the reason why I put this is to have I guess, a visual image of how many guidelines there actually are when it comes to ethical challenges. Um, so again, you cannot go wrong if you go by the guides, and I think we'll see that later when we go through the ethical decision making model. We shall see. But again, ethical standard 4, privacy and confidentiality. There you have it. We've got the maintaining confidentiality, discussing limits of confidentiality, more APA guidelines, um, minimizing intrusions on privacy, disclosures, how to make your disclosures and whatnot. Everything is here to guide us. And then we move on to the ACA strategy to address, well, they tell us basically what to do too, or they guide us into what to do too. We need to be aware of multicultural diversity. And the reason for that is it, confidentiality and privacy do have cultural meanings. So there are different meanings for different people. So it's just something that we need to consider. And of course, we've got straight off to get respect for privacy, respect for confidentiality, an explanation of limitations. So the APA and the ACA are on the same page when it comes to that. We have to let folks know, hey, if you tell me this, that, or the other, I have to let people know that. Okay. The last ACA I put a lot of words in here that apparently I cannot pronounce, so that's unfortunate. Applicable guidelines. There we go. Section B of the ACA, confidentiality and privacy, and then exceptions. We're letting you know, or they're letting us know. Serious and foreseeable harm and legal requirements. So again, there are certain things that we have to disclose. We have to break confidentiality for this, and this reason. It's imperative that we explain that right out the gate. Minimal disclosure. Again, a guide in how we use our disclosure, what we need to do about that. Just briefly, let's look at informed consent. And I say briefly because it ties right into privacy and confidentiality. Whereas when it comes to informed consent, this has to happen at the beginning, right? Um, Talking about all the limits and stuff, but also we have to keep in mind that our clients have a right to know. We as clients have a right to know, right? Depending on what we're talking about. But I think, the clients really want to know what services that their agencies, organizations, whatever provide, and what are the specific roles of the people in the multidisciplinary team, for instance. They're going to see people walking around occasionally. Who are these folks and what are their roles? Oh, and credentials. That's always nice to know. Just kind of a base of reference through, what their credentials are. Agencies that offer peer support programs, again, provide clear descriptions of the role of the peer support specialist, information about professional boundaries and confidentiality. There's numerous research out there that says this is what we need to do. And kind of eliminating a barrier, I believe, is being transparent with people that you work with, conveying the information right out of the gate to the active duty, especially to the active duty service members and the veterans that we serve. Um, what we've seen is this actually increases their willingness to enter into programs and then more fully participate, whether that's through um, different disclosures, different level of disclosures, um, providing feedback, so on and so forth. And again, the APA and the ACA have these guidelines that really do help us with these challenges. With, it's a great strategy. Hey, informed consent, this is what I have to do. These are the rules around it. I've got 4 different sets of rules depending on the situation. This is, obviously how I need to handle informed consent. And then in ethical standard 10 under therapy, that's when you really get to um, talking about it early on in the relationship and then ongoing as things occur if they do. So the ACA guidelines here is, again, Section A, the counseling relationship, informed consent. In the counseling relationship, again, the ACA is right along par with the APA in that. And then the development and cultural sensitivity. I'm seeing, obviously, a pattern in that. It's important for when we address these things to be very mindful of that it's culturally appropriate, right? That it's that we're maintaining our cultural competence, which is outside the scope of this presentation, but just something for you to think about. Being culturally competent is actually something that I personally strive for all the time, because I'm never going to be completely culturally competent. I'm not even culturally competent about my, say, Irish heritage. So, but that's a story for a different day. All right, let's move on to boundaries and dual relationships. This is a biggie, and this is the longest section when it comes to ethical challenges, because of most people get in trouble for violating the boundaries and dual relationships. We'll get into the details here in a minute, but this in particular is one that we see a lot. Boundary violations, establishment of prohibited dual relationships, not just frowned upon, but prohibited. Subscribe to my professor, and a shout out to Professor Fred Stone. Hey, I know you're going to hate this when I say this, but they're not professionals. PSSs generally are not professionals, at least not when you start out, right? Can you go on to further education and become a clinician? Of course. Do I highly suggest that? You betcha. But because peer supporters aren't professionals per se, and I'm saying per se, some of the clients clients that we're trying to get into the program, they fear that individual PSSs are going to demonstrate poor boundaries, like going out to coffee with only one other member of the PSP, or making treatment recommendations. You're not trained for that. Don't do that. But they fear that that's something that's going to happen because of the lack of, I guess, credentials, essentially. And of course, it's in the name. You're a peer of those you serve. So crossing boundaries and creating dual relationships is extremely difficult to avoid, especially in military cultures where fidelity is emphasized, right? I went and looked this up. I think my brain went on a tangent. And I looked this up because Semper Fidelis, I never knew that it meant always faithful. So I just wanted to throw that in there. I thought that was really interesting. So something to think about too is there is a chance, and it becomes an ethical challenge, when a peer support specialist becomes, well, I guess essentially moves up from client to provider of services. And I mean, that's exactly what I did. Before I was a trainer, I obviously was a peer support specialist for quite some time. Um, and so changing roles can create quite an ethical challenge. I mean, like if you were in mental health or substance abuse treatment with the people that you're serving now, that can be a little, I don't know, maybe awkward, I would think, maybe. Relapse is a real, what shall I say? When it occurs, it's a real challenge because peer support specialists have to step away, right? You, and this is another awkward moment, I think, when, say, if I relapsed, I would have to go back um, into my recovery because back into like intensive, engagement with my therapy because, like I said before, and as a reminder here, successful recovery engagement is a must for peer support specialists that are working. It is a must. So, it, you know, when there's relapses, which happen, statuses change, and it affects, of course, the ability to provide services. Again, another situation where you must step back. Adding to this challenge of boundaries and dual relationships, you know, you're in treatment with these folks, you're peers with these folks, you may have served with these folks. They know a great deal about you as, um, I mean, just as a peer, I guess, regardless of your role. So we've seen that complicate working relationships every once in a while, but it's just something that we need to be aware of. Another challenge that might arise regards self-disclosure um, of our private and confidential information, and where do we draw the line, right? This is an ethical challenge for sure, because as a peer support specialist, you're not just encouraged to, but you're expected, like Chenman says here, willing and open to sharing their experiences with clients in an appropriate manner. Got to do it. It's part of the job. So, a couple strategies to address the clinical challenges of the boundaries and dual relationships. I'm going to refer to this a little bit more later, but the New England Peer Education Center teamed up with the VA to create, I think we talked about seminars and workshops and different things like that. So regarding like specifically regarding a recovery story, it teaches, especially new peer support specialists, it teaches them how to develop an effectively used recovery story as part of their arsenal, shall we say, their toolbox. Again, trainers and supervisors, I do think it's important for the recovery story to be um, heard, approved, monitored as time goes on. Um, we, in the service of people that we serve, that's how we disclose our information. It's not for us per se. It's not against us by any means, but it's more in the service of the people that we serve than, how it makes us, how our recovery, telling our recovery story makes us feel. Okay. And, um, you know, since most of the peer support models are based on informal relationships between the peer support specialists and the PSP clients, um, the boundaries are the informal relationships make for ambiguous boundaries. So Chinman, oh, and Johnson, forgot that guy, gave us a few things to be aware of and adhere to. Um, a lot of clinicians and other mental health professionals will be a little bit wishy-washy about this kind of stuff, but um, I do think that this is very good set of four nevers that we need to be aware of and certainly adhere to. Never engage in sexual or intimate activities with a client, period. Never accept gifts. There's a lot of research that goes back and forth on this, um, cultural considerations when it comes to this. Um, but again, at least starting out with the blanket rule of not taking any gifts from clients, I think is a good idea. And there are ways that the different seminars will actually help you discuss, no, I can't, and this is why, and so on and so forth. Never give your home address to a client. Just don't. And it's highly, highly suggested to never enter into any business arrangements, financial arrangements, or the like with a client in a peer support program. You know, not all ethical challenges are as easily identified. We call these gray boundaries, and it's important for individual peer support teams to um, talk about these challenges within themselves because, I can have a group of PSSs, a group of PSSs, and a group of PSSs, and give you all some sort of ethical challenge. It could be about anything, boundary, dual relationships, whatever. And my bet is on all three of those groups having completely different answers, or maybe not completely, but certainly different aspects. Um, so yeah, a couple of questions that represent gray boundaries. One I kind of brought up earlier is it okay to meet a client, say like after hours at a coffee shop? Is it okay to give one of our clients our personal cell phone number and be like, "Hey man, call me anytime. I'm here for you." Call me anytime? I don't know. Should we be invited? This is a tough one for me because I'm a pretty social person. But should we be invited to social activities away from the workplace? And then, of course, if we are invited, do we go? These are just some gray boundary questions to toss around and to think about. Oh, I should also say here, being able to, again, discuss the ambiguous boundaries, ethical challenges. It's incredibly important part of the supervision process. Um, as a PSS, you'll be in probably weekly or biweekly supervision meetings with the clinical supervisor of your PSP. So it's important to be able to respond correctly when your supervisor says, hey, I got a little ethical challenge for you. What would you do in this case? It's always good to have an idea of what to do. And again, the strategies, APA and the ACA has really strategies for anything if you think about it. Maybe not word for word, but certainly if you really look into the codes and the standards, you can find things to apply to pretty much what I found anyway, pretty much any ethical challenge. So here, I mean, the APA and the ACA do not play about this kind of stuff. The ethical standard 3, human relations, sexual harassment. Now, I pointed that out um, because the potential in a relationship is there for someone to be accused of sexual harassment. And again, that's outside the scope of this particular presentation, but it's important that, what shall I say, certain things could be interpreted as sexual harassment and then really come to bite the, it could ultimately be the team on the backside. So stay away from sexual harassment. We've learned that over and over and over again. And then again, the APA code gives us 3 different, very detailed sets of how to deal with multiple relationships. And basically, it's a suggestion to stay away from them. Talking about conflict of interest when it comes to, I think, essentially dual relationships, and then being exploitive. Again, I think some behaviors can be interpretive, not the way that they were intended per se. So, being sure to just never be in any kind of an exploitive relationship with anybody you work with. I would think that that's a best practice. So in ethical standard 10, therapy is when the APA really, really lays it down. Sexual intimacies with current therapy clients and patients, sexual intimacies with relatives or significant others of current therapy clients and patients. And then this one kills me. Sexual intimacies with former therapy clients and patients. And thankfully, it gives us a timeline of we can't have any kind of sexual intimacy with a client until 2 years after our, I guess, official or a therapeutic relationship has been terminated. So that's good to know. Now, the ACA, it looks very similar as you would expect. Prohibited non-counseling roles in relationships, sexual and or romantic relationships prohibited, previous sexual and or romantic relationships, sexual and or romantic relationships with former clients, they went a little bit farther, personal virtual relationships with current clients. And the way I see that is stay off of Facebook. Just stay off of Facebook. Another strategy is to go with the ACA guidelines. Section A6, managing and maintaining boundaries in professional relationships. Again, they're talking about previous relationships, extending counseling boundaries if you ever need to do that, and how to handle that. Documenting boundary extensions. If you do have to extend a boundary, you need to make sure that you document all of that information in the client file. All right, managing and maintaining boundaries in professional relationships again. Non-professional interactions or relationships other than sexual or romantic interactions or relationships. Something we need to avoid. And the ACA does talk about receiving gifts. I do want to kind of look at this one. Counselors understand the challenges of accepting gifts from clients and recognize that in some cultures, small gifts are a token of respect and gratitude. When determining whether to accept a gift from a client, counselors take into account the therapeutic relationship, the monetary value of the gift. That's where a lot of the research kind of conflicts, and actually where the research really what agrees on is what is the motivation for the gift from the client, right? We need to really look deeply into that. And then, of course, our motivation for wanting to accept or decline it. And then how do we decline it? I think there's a workshop for that. Anyway, when we deal with public responsibility, we're not to sexually harass anyone. Talked about that in regard to the APA guidelines. And then again, don't exploit other people. We don't want to be exploited in any way, shape, or form. So I certainly, don't want to exploit other people. Continuity of service is a big deal. We kind of spoke about that in previous sections. Here, I think regarding relapse, PSSs may very well succumb to relapse. We're human. Um, but what that does is cause a break in the continuity of services, which is essentially like dropping the ball or forgetting about a client, which would be horrible. Um, and like I said before, in the case of a relapse, mental health professionals at any level need to step away and take care of themselves. The thing is, as a lot of us know, relapse is completely manageable, right? In regards to how to address that with a peer services program, relapse is manageable. And I have what, 4 ifs here. If, I'm just going to say if we're treated with fairness and respect, if we're allowed to take the appropriate time off to work on our issues, right? If our supervisors provide the coverage necessary for none of our sessions or groups or anything that we have planned to be canceled or rescheduled, that actually, I believe, needs to be a primary policy. Yeah, cancellations are not good. Reschedules are not good. Doing what we can to make sure that all of these programs stay on track, need to do that. That is a way that relapse is manageable by not dropping the ball, by continuing client services. And then, of course, when we're ready to come back, having our supervisors, in particular, support us, um, get us right back into our supervision cycle as we, are preparing to go back into our professional role. And what I just thought of was part of this is going to be revamping our recovery story, right? We had a relapse. Our recovery story has significantly changed, and we need to run that by our supervisors before we start using that recovery story as one of our recovery tools. Just real quick, the APA guidelines for continuity of service. It talks about what to do in the case of interruption of psychological services, and again under ethical standards of therapy, talking about interruption of therapy specifically due to, I mean, we're talking relapse, which is viable, but also this is talking about like changing employment, uh, changing positions within an agency and not being in the same capacity in the peer support program. And then, of course, when we terminate therapy, there's definitely things that we have to be very, very conscious of so it doesn't become um, an ethics violation. But again, like I said, the APA and the ACA are very um, thorough, shall we say, and clear about the expectations. Here we have client welfare. And what I thought was kind of interesting is when I did a search on um, the APA guidelines, the only time I saw continuity of service was in this, and it's for records and documentation. Um, yeah, it's the only time that I saw it in the whole of the ACA Code of Ethics from 2014, which is the most recent. And then the ACA also is concerned about termination and then referral, or what I've been taught is what's called a warm handoff, right? We don't leave anybody behind. Didn't in our service, and we're not going to do it now. So we need to make sure that we follow the guidelines of the APA and the ACA when it comes to transferring our clients or needing to um, put an end to the therapeutic relationship in one way or another. Here it talks about abandonment, and client neglect. That's a big one. Um, Seems to be a lot of complaints around that. Clients feeling like they were dropped, right? So there's a section around that that addresses don't do that. Professional competence, again, as with the APA, it says, you know, if the counselor is incapacitated, which at least for a little while, a relapse would be considered, right? Death, I mean, gonna have to transfer clients after death. Retirement, of course, happy situation, but not so happy, I think, for clients who adore their therapists that are like, I've done my 25, 30, 35, 40 years or whatever, and I'm done. Um, but I'm going to make sure that your your case goes to somebody that will be aware of your situation and be able to help you from here. One of the last ethical challenges that I want to discuss is countertransference. And that's just basically when we're in deep, right? We're really providing these great services. Um, but the problem is, the challenge becomes we start to over identify with our clients or the person that's seeking support from us. And over identifying can, first of all, it's counterproductive. It can actually trigger a relapse, set people really back in their recovery, possibly harmful. A setback in recovery would be very harmful. And then, of course, having to step away from your PSS services, right? That's harmful. Like I said, there's 1,200 paid peer support specialists in the VA right now. So, you know, if you get to that stage, you don't want to lose it. So this is, we have to be able to be, we have to be able to manage relapse. Recognizing that we're struggling with the transference or with the over identification of the client. Again, step away. I can't say it enough. Our our self-awareness will dictate, I think, essentially as mental health professionals, that we step away. In the spirit of continuity, and kind of what we said before, a strategy is to make sure that I've heard that the PSS should actually find a replacement. I don't think that's something that somebody in relapse needs to be concerned about. I think the team needs to be cohesive enough that if the peer support peer support or supervisor, peer support specialist has a relapse, something goes on, the services have to go on. The show must go on, right? Essentially. Competency and expertise is another, that's a big one too, because again, sorry, Dr. Stone, but most peer support specialists are not formally educated, per se. I mean, like out of high school or, because a lot of them went straight into the military and then came out and haven't gone on to that next stage of education, um, which I can appreciate because I want to talk them into going into therapy, of course. Oh wait, as a student, because they're already a client. Anyway, since they're not social workers, they're not psychiatrists, they're not psychologists, they're not LPCs, psychiatric counselors, nurses, all these people that people fear that they won't be as ethical. And we kind of talked about this before. Um, if you they fear, if you haven't had advanced ethics training, how can you train us or whatever? Um, but because they're not professionals, the fear is poor boundaries will be demonstrated. Again, we talked about this before. Making treatment recommendations is probably one of the most serious boundaries that can be violated. Medication, um, any kind of, you know, advice that you may have about their psychotropics or anything like that's certainly a demonstration of poor boundaries. So again, I touted the praises of the peer specialist toolkit at the beginning of this. Um, again, another strategy to address competency and expertise is to learn, right? So to increase competency and subject matter expertise, the New England Peer Education Center developed these seminars and what do they say? Seminars and workshops where we can acquire new competencies that are required for the PSS certification. And as they say it, the education is structured to promote knowledge acquisition and skill enhancement related to mandatory competencies expected of PSSs working for the VA. So these are extremely handy. And this will soon be you. So let's just look real quick. I'm not going to go through all the brief descriptions. Like I said, you have this in the packet of information that I emailed you. But let's just look at some of the titles. They're actually pretty self-explanatory, which is nice. Confidentiality and peer support services, super helpful. Disengaging from peer support relationships. Part 1, group facilitation skills, training series, planning, starting, and sustaining a peer support group. And then there's a part 2 to that, group facilitation skills, training series, dealing with challenges in a peer support group. So more, I believe, extensive than this program or than this get it writing. Then this presentation, I would highly suggest you look into that. Making effective use of your recovery story in peer support relationships. Now, this is what we've talked about. It's incredibly vital to have these buttoned down. So the more you can learn and practice recovery story, the better everyone is going to be. Navigating boundaries in peer support services. Super helpful. Peer support provider. This is so important. Walking the tightrope between helping others and maintaining your own wellness. I mean, you're all veterans, from what I can tell. you're all still, pretty fit, but it's not just the physical fitness, it's the mental fitness and the mental wellness that's extremely important as well. So I highly suggest you take a look at this seminar. And then lastly, psychosocial rehabilitation and peer support and understanding mental health symptoms from a recovery perspective. So that just seems to be a pretty comprehensive list of how to gain a ton more, um, just a ton more knowledge when it comes to being a peer support specialist, and I think peer support programs just in general. So, of course, the strategy to address competency and expertise, the APA and the ACA both have a lot to say about. Um, I think essentially staying in our wheelhouse, right? Um, there's boundaries of competence that, again, I'm not going to read all the way through, but there's 4 pretty healthy sets of um, boundaries of competence that the APA, utilizes as guidelines. Competence, we have to maintain our competence. Um, and then just to add into that, I put that the general principle that we talked about before, general principle D, is justice. And again, psychologists exercise, or mental health professionals exercise reasonable judgment and take precautions to ensure their potential biases, the boundaries of their competence, and the limitations of their expertise do not lead to or condone unjust practices. So that's pretty clear. The ACA, much the same, um, talking about how to be competent when we terminate or refer someone out. A lot of guidelines around that, which indicates there's been some significant problems with that particular guideline in the past, right? Professional competence is, a section all of its own, talking about the boundaries of competence, such as what the APA was doing. New specialty areas of practice. I like this one, actually. I'm going to read this one. Counselors practice in specialty areas new to them only after appropriate education, training, and supervised experience. While developing skills in new specialty areas, counselors take steps to ensure the competence of their work and protect others from harm. I love that. I feel like my level of nerddom has completely increased in the last, what are we at, 8 weeks of this ethics course. I'm a proud ethics nerd. Um, Again, the ACA talks about continuing education, seeing the need for, hey, here's a new treatment modality or a new theory or something really interesting to think about or implement. Educating yourself in that way is um, certainly something that the ACA guides us on. Again, professional competence. There's limits to our professional competence. We need to be aware of that, not step out of our lane, work out of our lane in any way. And then counselor educator competence. If we're counseling well, not only when we're counseling somebody, but when we're teaching somebody, we need to be competent in what it is we're teaching. So you can decide that after this presentation if you'd like. All right. So Chinman in the peer services toolkit was very gracious to kind of put things in a nutshell for us, with safeguards intended to prevent ethical challenges from arising. Okay, so from even being an issue, from coming up at all. All of the training for peer support specialists cover ethical challenges in detail. So again, the education that we are provided, you're expected to know that. The clinical service that you work for should adopt specific policies to address the ethical challenges, like I talked about before. Every team is going to come at an ethical challenge from a different lens and have a different solution. So making sure that the team is um, congruent in the way that they feel about it, that can definitely prevent ethical challenges from arising. Um, and all of these things need to be made clear again at the beginning when a PSS is hired and throughout. This is information that we need to know. Ethical challenges should be a regular discussion during all supervision meetings, which is what I was saying. This needs to be a consistent conversation. If peer support specialists violate any ethical standard, they're going to be held accountable. I'm going to be, you're going to be. It's extremely important. Any employment or any employee of the organization would be held accountable. So why would we be any different, right? Excuse me. A little sip of Dr. Pepper there. All right. So we're moving into the last stage of the presentation, and I just kind of wanted to stop real quick and ask, does anyone have any questions? Are there any concerns or any comments at this point? All right. Well, let's move on. So let's talk a little bit about the value sets of the United States Armed Forces. I talked about this a little bit earlier, but I wanted just for people that don't know, that's in the I mean, you may know specific um, your specific values, but you may not know those of the other armed forces. So the Army is loyalty, duty, respect, selfless honor. Oh, my bad. Selfless service, honor, integrity, personal courage. The Air Force is integrity first, service before self, and excellence in all we do. The Navy has, well, the Navy and the Marine Corps, as we know, it's under the same umbrella, um, and it's honor, courage, and commitment. We're hearing a lot of honor, honor, honor. The Coast Guard is honor, respect, and devotion to duty. When ethical challenges come up, we not only as a peer support specialist, but within a peer support um, program, the team has to be able to resolve these ethical challenges um, in an ethical manner. That makes sense to me. I hope it makes sense to you too. So before we move on, though, I want to open this question. What factors do you think could potentially impact ethical decision making within peer support programs? So like when something comes up, what kind of factors do you think, I guess, impact or potentially impact the program's ability to make an ethical decision? So I came up with just a few, and again, I'm not going to exhaust this because you do have it in your packet, but some your individual culture and your individual characteristics obviously are going to impact how you think about an ethical challenge and then the way you approach a challenge to strategically solve it. Um, so I actually really liked this researcher saying his article is actually really, really interesting. It's in your resources. He says, since not everyone internalized the same moral code through their upbringing, ethical decision making, especially within a culturally diverse PSP program, could be impacted. That makes sense. people's individual beliefs, morals, and values obviously play a role in the way they think through an ethical challenge. And one example of that is religion. Um, you have one PSS that is very, very faithful, puts um, a lot of emphasis on their religion, adhering to their religion and whatnot. And then you have a PSS who is like, I'm not down, like I'm not into that. I'm not religious, or I'm a different religion, shall we say, which would come at an ethical challenge in a different way, perhaps. Um, so Zhang being Chinese, I think he's said he was Chinese American. He said that the Chinese culture places higher value on how their decisions impact their system of social relations. But Americans are more bent on, like what he said, following a compendium. Love that word, compendium, or a compilation of specific rules to guide their ethical decision making. So they're more worried about the system of social relations. We're more, whereas we're more worried about, as Americans, following a list of specific rules, which, to be honest, I'm guilty of. We're gonna, like I said, talk about briefly ethical decision making model, and I do this. It's 8 steps. All right. More factors that could potentially impact ethical decision making models, ethical decision making in peer sports programs is the military culture. Now, I didn't go into great lengths because you're all military people and you understand, but two things that I pointed out was through that enculturation process of the military, not just initially, but throughout service, um, service members being taught to put the team over the individual, that could become a challenge, right? Um, if you're worried about the team dissolving, um, and you're placing that over the individual, that can certainly impact how the decision making, it can impact the decision making, shall I say. Um, and another issue, and I want to open up two questions here, is one of the study in 2017 found that the majority of the clients working in a peer support program, of course, they have an enduring sense of veteran identity. That's awesome. However, there it becomes a little bit of an ethical challenge when um, the clients feel like it's absolutely crucial, right? Anybody who is educating me on anything has to be a veteran. They have to be a veteran, or they just don't understand me. They haven't been there, done that, right? So, unfortunately, the WEIR study in 2017 also found that veterans just simply, the ones that they studied, they just don't trust civilians. Okay? So, my question to you is, how do you think your PSP would be affected if the clinical supervisor you end up hiring um, isn't a veteran? I mean, how do you think your PSP is going to react? More so, I want you to think about, how would you be affected? How would you react if a clinical supervisor came in that wasn't a veteran? Just something to think about. And then, of course, our ethical philosophy and perspective. Now, I totally well, frankly, I geeked out on this, and um, I just find it very interesting. Philosophies, um, theoretical lenses, different perspectives we have about different things. I find it pretty fascinating actually. So, just briefly, rule consequentialism. This is when um, the view that it's morally wrong for somebody to do an action if and only if that action violates the ideal moral code. So that's pretty straight to the point. Consequentialism is when you evaluate the moral worth of an action based on how much it contributes to the social harmony of the state. So again, rule consequentialism is what Zhang found. Americans were more rule consequentialists. I put so many hard words in here. I don't know why I did that. State consequentialism, again, is the harmony of the state. It's in the name. Utilitarianism, that is a behavioral code, or saying that a behavioral code is morally right if the consequences of adopting it result in the greatest good for the greatest number of people. So again, utilitarianism is how can we how can our decision impact the greatest number of people? And team over the individual kind of fits in here, right? All right, ethical relativism. I can say that. Ethical relativism. That is the view that moral standards are grounded only in social custom and believe people should not pass judgment on practices in other cultures when they do not understand them. All I can say is amen to that. And Confucianism, there we go. Confucians are those that, and a lot of Buddhists in much of the same way, advocate the oh, talk too long, differentiated obligations toward friends and relatives than strangers, and consider human relationships more important than any other aspect of life. So that's pretty intense. That is that is very, very, very cool. All right, swear this is the last. Absolutist or rule-based thinking. That kind of goes along with some of the others. An individual's actions can only be judged as ethical if he or she is basing those actions on a principle that he or she would accept as universal and applicable to all. So again, absolute, applicable to all. Universalism. That is a stance that honors diversity, but lifts up universal moral principles that are common to most cultures. And then caring and reciprocal empathy, which is something I hadn't heard of in this context before. Caring and reciprocal empathy as a philosophy or perspective involves being able to enter another's world, cognizant of one's own cultural background and of one's impact on another individual based on power and privilege. So yeah, Freeman Williams went crazy on how different cultures are treated, cultural backgrounds and so on. That's actually a really good article. I highly suggest reading that. But the caring and reciprocal empathy, it includes knowledge of another's culture and presupposes a relationship in which difference is honored and values are not imposed on the other individual. A couple of thinking errors that I just want to go over, thanks to Pope and Vasquez in 2016. Ad Hahnemann, there we go, Hahnemann, and ad feminen. That's attempting to discredit the opinion or position of another person by drawing attention to their characteristics of that person, which shouldn't be related at all, right? Appeal to ignorance, that's another thinking error, and that's assuming that if there's no evidence that something is false, it must be true. Cognitive bias, McCombs School of Business, I know that sounds crazy that I pulled that, but it honestly was the most comprehensive list of cognitive biases that I could find. So I appreciated that. Overconfidence bias. If we're overconfident, we tend to have insufficient value in others' opinions. That can impact ethical decision making within a team big time. Confirmation bias. You might have heard that one before. It's the tendency people have to process new information in a way that is heavily influenced by their existing beliefs. The anchoring effect is kind of the same thing. People's initial focus on a particular fact or number means they fail to properly adjust their judgments as new and different information arises. So you're anchored, you're not moving, you're not budging, and it creates a cognitive bias. And then overgeneralization. I think a lot of us are pretty systematically guilty of that, actually. The tendency to jump to a broad conclusion based on a single piece of evidence. All right, factors that could potentially impact ethical decision making in PCPs. The last thing I want to talk about are logical fallacies, and Pope and Vasquez gave it to us. Naturalistic fallacy. That's logically deducing a value such as what is good or ethical, but by only looking at statement of fact. So very objective. Nominal fallacy, on the other hand, is this one I find really interesting. Assuming that a name has explanatory value, if something has a name, this means that it is understood as such. And I came with this example of, so your counselor points out to you that you're using a defensive mechanism. Amy, you're developing or you're using a defense mechanism, blah, blah, blah. And then I'm like, oh, okay, well, but the problem is there's no further explanation by the mental health therapist, or the counselor because, well, I told you you're using a defense mechanism. And you're like, I know, what the heck is a defense mechanism? And then a composition fallacy is making the assumption that an entire group shares the characteristics of the single individuals within it. So this really comes to play in military PSPs because you're all veterans. So can you see where that could potentially impact making an ethical decision on a challenge? So when PSPs are facing ethical, clinical, or legal issues, it's helpful for the PSP team to follow an ethical decision-making model to help resolve the issue. This training utilizes steps 1 through 7 of the ACA practitioner's ethical decision-making model, and I also, as I said before, I added a step 8 because I think the fact that it wasn't in this decision-making model was a little strange. So just right quick, this is the 8-step decision-making model. Identify applied code of ethics, determine the nature and dimension of the dilemma, generate potential courses of action, consider the potential consequences of all options, and then determine the course of action, evaluate, implement, and then review the outcome of the action was my addition. So this is the very last part. We're going to go through a decision-making model. Just real quick. All right. And because this is recorded, I wasn't able really to do this kind of in a step form, shall we say. So I went ahead and made a worksheet to make it a little bit easier. And I do want to read through this as it's part of how we're going to make the ethical decision. Is the first thing we have to do is identify the problem. So one of my clients in the PSP that I clinically supervise has asked me to provide couples counseling to him and his husband at my private office. I've supervised this PSP for 2 years, and my client is a founding member. We have always maintained a good relationship, and he tells me that I'm the only LGBTQ plus therapist he trusts to help him and his husband with their marriage. Although I have some training in marriage counseling, I'm not an LMFT, which is a licensed marriage and family therapist. The client knows this, though persists in his attempt to get me to agree to counsel him and his husband. I'm tempted because I really care about this client and his well-being. And the last time he spoke to me, he had tears in his eyes telling me that he and his husband were at a breaking point and they were desperate for help. Big problem. So, naturally, the second step is apply the ethics codes. Well, when I do so, and as we kind of saw before, it is unethical for me to form a dual relationship with a client in my PSP. Pretty direct, right? It's also unethical for me to practice outside of my scope of knowledge and training. So that's something that is vital to keep in mind. So when we move on to the next steps, it actually isn't as hard after we go through the ethics code. But let's go through. So step 3, determine the nature and dimensions of the dilemma. I just did a little brainstorming here. I'm flattered the PSP client thought to utilize me as a therapist, and I understand that he trusts no other LGBTQ plus therapist to help him and his husband through their marriage or marital problems right now. I do understand that. As a clinician, however, I am to do no harm, right? That's huge in the APA, that's huge in the ACA, AMA, all of that is to do no harm. But I feel like in some ways, rejecting his pleas for help it could possibly hurt him and his husband. Fourth step, generate potential courses of action. Okie doke. Again, more brainstorming. I could schedule an initial appointment with him and his husband at my office to get an idea of specific type of help they're looking for. Even though they've already said they're looking for marriage counseling, I would look, a little bit deeper into that. And frankly, if I think I can help them, I should probably help them, right? Or I could tell him about the APA and ACA codes of ethics and the fact that I adhere to those codes of ethics, and just explain to him that I can't be his therapist. I can't create a dual relationship, but I can help him find another therapist, right? So, step 5 is consider the potential consequences of all options and determine a course of action. If I do take the client and his husband on as therapy clients, I'll be violating, like I said, the APA and the ACA code of ethics. However, if I don't take them on as clients and they or we are unable to locate an appropriate alternative, they particularly need an LGBTQ therapist that is an LMFT or a licensed marriage and family therapist. So very specific needs. That's not me, right? But if I don't help them and we can't find a suitable alternative therapist, I worry that the issues will compound and it could result in negative situations and consequences. So, what should I do? I mean, what do I do? So the course of action, I decided not to take the PSP client and his husband on as my therapy clients. Yep, that's what I decided. What course of action would you have taken? Would you have done anything different? Would you, well, I'll just leave it at that. I want you to think, um, what course of action would you have taken in this situation? What would you have done? Okay, so I want you to think about that. The last two steps, evaluate the selected course of action. Okay, so I decided I'm not going to take him on as clients. In order for me to remain in compliance with the APA and ACA Code of Ethics, it is in my best interest and ultimately in the best interest of the client that I do not engage in a dual relationship with him. As the clinical supervisor of his PSP, I hope my decision does not cause any harm to him or his husband, and that he and I maintain our long-standing positive working relationship. I will still offer to help the client and his husband locate and connect with an LGBTQ plus LMFT and hope they accept my offer to assist them. All right, implement the course of action. So I caught him in the parking lot, and I let him know that, I explained to him that I wouldn't be able to take him and his husband on as therapy clients, and I explained all of the reasons why. Okay. And then the last action, or the last step, is the one I added, which is review the outcome of the action. Okay, so a little time has passed. Although he said he was disappointed, later in the day, he reached out to me and told me he understood why I couldn't take him and his husband on as therapy clients and graciously accepted my offer to help him find the LGBTQ LMFT. This is a good outcome. It's much easier for them to utilize an LMFT. That's what they're in need of because they need marriage counseling. So it's good for them to do that. And lastly, it's best practice for me or you in the decision making to adhere to those codes of ethics. Again, whether you're directly under the APA or the ACA, it's still a really good set of ethics standards and guidelines to go by when facing an ethical decision. So that's all I have for you. Are there any questions, comments, or concerns about anything that we've went through? All right. Well, thank you all very, very much for your time and attention. I apologize it went over time. It's just a lot of information that I wanted to make sure that you got preliminarily before you went on to the next steps of your certification. And lastly, the references. I want to make sure that you all have these. I kind of pointed out throughout that some of these articles are just fantastic. If you're a nerd like me, you'll probably read all of them. All right. I did create an appendix here. You guys do have this in your packet. This is the actual flyer that the VA uses. It's a 3-part dual-sided flyer. So here's the first set here, the front side. I guess essentially it becomes the back side too, but that's that. Whoop, and then the back part of that. So that just wraps things up in a really great little flyer there that you can print out or access online. All right. Again, I'm Amy F. Blackman. I am a graduate student at CSU Global in the Military and Emergency Responder Psychology program under Dr. Fred Stone, who has graciously watched this almost 2-hour presentation, and I couldn't appreciate him enough. So thanks everybody. I appreciate your time and attention, and that's all for me.